There is an incredible amount of very helpful health data at our fingertips, but it can also be very misleading. That misleading conclusions can deeply impact our lives. How can these Ayurvedic Śad Darśanas, these six ancient schools of thought from India, help us in healthcare make better, more personalized, more informed decisions? What happens when standard health metrics do not include you? When you were excluded from the trials, the clinical trials, that could be everyone in this waiting room. So before we dive in, I just want to say, I am so grateful and I recognize what a great opportunity it has been to practice internal medicine for 25 years. And most of those years, I was also involved in pharmaceutical clinical trials. I'll say that the knowledge I've gained as well as an Ayurvedic practitioner has been so eye-opening, so pertinent and helpful for my practice and for my own personal health. This is my webpage, my website. If you ever seek Ayurvedic consultation, this is how you can reach me. Or if you want to see another webinar about heart disease and, in particular in the South Asian community. So just like this laser in the right hands and skilled hands, yeah, indeed, pharmaceuticals can do immense good. I do practice medicine with the conventional therapy, statins, GLPs. I've seen amazing things, but their precision does delve under real world constraints. As hard as it is for physicians and healthcare providers in general to serve their patients as best as they can, we are limited in time, in insurance and administrative burdens, and there's just an overwhelming amount of data to sift through that we have to recognize. So in such an environment, these people can be left out. And we're going to use the epistemology of Ayurveda, the core principles, to expand how we can include those who have been underrepresented in clinical trials or are facing barriers in healthcare. And I want to emphasize that this isn't about putting Ayurveda beyond scrutiny. Its therapies should, in modern sense especially, meet rigorous standards of quality and some evidence and logic. This talk is not about Ayurvedic herbs, but it's about something deeper. It's about this Ayurvedic knowledge system using these ancient algorithms to help healthcare navigate the complexities of human health in this ever-changing world. So very briefly, we're going to go over the six schools of thought in Ayurveda, and then we're going to give some real-world examples of some of these precepts. Nyaya is the knowledge system of critical thinking and systematic reasoning. Vaisheshika explores matter, atoms, the nature of the world, the physical world. Sankhya focuses on consciousness and the interplay of matter and energy. Yoga is the knowledge system of meditative and physical disciplines connecting to the deeper center. Purva Mimamsa deals with ethics and karmic law, just kind of like law of action and reaction. And Vedanta examines ultimate reality and self-realization. So there are overlaps with modern Western science, but there are definitely uniqueness in each of these areas. There's a lot of talk by even quantum physicists relating Vedanta and its understanding seems to be even a deeper level than quantum physics, but there's some parallels. So let's just go into it. So this article talks about how statin therapy to treat coronary artery disease in America in adults, almost 27% or somewhat less of the adult population has been or is on a statin. And they say, well, there's poor representation. It varies, and probably a lot more people is the talk that should be on it. However, it's these people in this waiting room, let's say, who were not properly represented in these big trials. So the studies did show a lot of good things, but many of these studies did not include people with low or normal LDLs and with high lipoprotein little a. They didn't specifically do the trials based on this number. They excluded people with high triglycerides. This is a specific type of milieu of a lot of patients. For example, South Asians. They had to exclude autoimmune conditions, severe kidney disease, people over 75, certain ethnic communities weren't really, I think they should better focus on females and postmenopausal issues. There's talk about how there was no analysis of nutritionally depleted people, and then to replete them and then check their levels to see if their risks went down. They excluded people with diabetes. And yes, you need your clinical trial to be clean. You don't want a million variables, but at the same time, then if you didn't really have many trials studying these types of people, then the guidelines have to be very specific to note that and to make sure that there's some representation, because there's no perfect system in this world, and we do have to make guesstimations, but these people need to be recognized. There is data that, in fact, very low bad cholesterol, very low LDL cholesterol is associated with higher risk. This is an associative risk. Nevertheless, it's something that needs to be explored, right? People who are elderly, people who have chronic illness and malnutrition, certain groups, populations, advanced heart disease. They are a lot of people in this waiting room. I had very few people with well-controlled sugars who frequently visited me. This is the population that is not represented. This article talks about how and I talk about this in my other webinar, but these nutrients, and a lot of people are going vegan and vegetarian, and that can be great for cardio protection. But if you don't monitor the holes in the diet, fortify or make sure that they're taken care of, that can be blunting to protect the heart. And, there's a lot of people in this population who don't absorb these nutrients, do not get them. And these tests, vitamin D, lipoprotein little a, B12 and its functional tests, and omega-3 index, they aren't routinely covered, and they can be expensive, right? They can add up. And so these people are not really included, right? So in Ayurveda, there's a recognition that there's so much data. This world is very pattern, so many patterns. It's like fractals, and you can't know every detail about everything. But when you glean certain data, like how the person's bowel movement is, how what's their body structure, how do they solve problems, all these little details you can piece together like a puzzle and use it as leverage to find some general trends to help every unique person, right? These individuals, one individual's treatment and diet is going to be another person's poison. And Ayurveda talked a lot about it and recognized long ago that certain types of body types need very unique attention, and they actually are at higher risk for these types of ailments that now we call cardiovascular disease. So there was this recognition and understanding the world is complex. It is made out of self-similar patterns, and you don't have to know everything about it. You just need to know some deeper rule sets so that you can guide a person, right? And we see this existence of what now modern science calls fractals. self-similar patterns all throughout. So back to these unique beings, kind of a fractal within the universe. Let's talk about specific statements. So, for decades, when we as physicians were ordering statins, we got a baseline liver test, and then we would recheck it, regardless of symptoms or not, in, 6 to 12 weeks. And now they're saying, well, you don't need to do that unless the person has symptoms. But there's a lot of people who are not going to have symptoms, and they're not going to be represented. So I want to talk a little bit about lipoprotein little a. So LDL is a bad cholesterol, oversimplistically put, and then lipoprotein little a can be this sticky rope-like thing that attaches to that little particle, and that's not good for your circulation and for the coronary artery disease prevention. And these are the populations that can have risk a high level of this lipoprotein little a. Including people who have heart disease and normal or low cholesterol. And again, those individuals, many of them are not represented in these studies. So, the current guidelines now are recommending checking a lipoprotein little a at baseline, but you really don't have to check it further because, lifestyle and other things don't really affect it, that kind of dialogue. But indeed, we know that statins actually can, according to this publication, raise your lipoprotein little a, that bad lipoprotein, by 8 to 24%. And there is, according to this study, that when you place a person on statin therapy and you actually do check their lipoprotein little a and it goes up, that increases their risk for a coronary event. So imagine if you're giving a recommendation, you don't have to check lipoprotein little a after you start a statin. It's not something that we do routinely right now. It's not covered. Imagine, for example, this population of South Asians, 2 billion, and they comprise 60% of the global burden of cardiovascular disease. That's a burden to them, but it's also, a lot of research and a burden to the world if we don't address the populations that are not represented in the studies adequately. So another statement is that we should get the bad cholesterol, LDL, below 55 for severe coronary artery disease. And if it's not a severe, less than 70. And there's no limit cutoff. And that's good for the people that were studied. But you have statements like this: the lower your LDL cholesterol, the better. We say you can't be too rich, too thin, or have too low an LDL cholesterol. Throughout the range of LDL levels, lower is better with no lower threshold. There are no adverse effects of very low LDL concentration. Now, this is a statement of, actually, it's absence of evidence and not evidence of absence. Or no, it is a statement of claiming to be that there's no evidence that they studied it, but they really didn't. And I'll get into that later. And these trials, for the most part, most of them were like 2 to 6 years. Now, if I did a study on young smokers, and I only studied them for 2 to 6 years, and I said, well, look, smoking doesn't cause lung cancer, did I really make a safe call about that? So in Ayurveda, the lack of perception is not proof of absence in all circumstances. And so let me give you an example, because there's a lot of phrases in scientific literature, in medicine, that go like this: there is no evidence of. But that is, what they really mean to say is that this area has not been studied. And the meaning is different. If I look at this forest and say, I've been here for like a minute, there is no evidence of Lyme disease, I actually should say, well, I didn't study it, or there's no evidence of bears. Well, actually, I didn't study it, right? And you see lots of those statements, and if you explore deeper, it's like a piece of a yarn on a sweater that kind of unravels with these statements. So let's dive a little bit deeper into lipoprotein little a. The consensus is that it's 90% genetic, okay, and that lifestyle has minimal to no effect on improving it. And there's really not many external factors that can change this. So now they're recommending just get a one time lipoprotein little a. But when you hear statements like this, actually lipoprotein little a can increase because of inflammation. So imagine if you had a normal liver, but then you started going on an inflammatory diet, gained some centripetal obesity, then this means that your lipoprotein little a can really go up. And if that's the case, and this article was really interesting, then they're saying that the statement that lipoprotein little a is not affected by diet and lifestyle is understudied, right? There's like really an absence of evidence and not evidence of absence. And in fact, they're starting to see that actually there is indications that this is the case, that lifestyle can modify it. So, we know that PCSK9, these are expensive cholesterol medicines, can lower lipoprotein little a, which is good. But niacin is, which is B3, it actually lowers it quite well, just like a PCSK9, 20 to 30%. But they say in this publication, it didn't really have a meaningful impact on heart disease. However, and again, this is where the specific, what we call in Ayurveda, the Vata Kapha predominant individual, that individual with high triglyceride, low HDL, and that type of thing, they were not really targeted in this group. And that's what niacin does. It helps lower triglycerides. It raises HDL a little bit, lowers cholesterol a little bit. But this article, when they did a post hoc analysis, they looked at the subgroup that had this risk, high triglyceride, low HDL. They actually found out that it does reduce cardiovascular outcome with niacin. Now, it's not a powered in retrospect, it didn't have enough statistical power or significance, but it is hypothesis generating, and you would think there would be tons more studies to explore and target this issue, but there isn't. And I don't know if it's because patented drugs, they have a lot of money to look at all of these different angles. But when you're talking about things that aren't really, very patented or like B3, maybe those studies just don't happen, right? And then these people don't get represented. So, in Ayurveda, there's a lot of literature on how you get knowledge, right? It can be through direct perception. You can see a fire, you can infer it because you smell smoke. You can make analogies of what fire feels like. You can postulate what fire is about. You can see that there's no fire, and you can rely on some authority that's trustworthy, right? So in a busy day, healthcare providers can't read every single journal, so they have to trust some authorities. And in Ayurvedic philosophy, and this sounds very much like scientific methods, right? You would make a proposal, you would give your reason, an example, you'd apply it, and you'd have a conclusion. And the type of debate you had was really important, how to identify that. And the last one is making sure you're not having a fallacious reason or pseudo proof. So they paid a lot of attention to that and attention to trustworthy source. And we know it's not, the general public knows that this has happened. This exists, right? The tobacco industry for decades, in spite of overwhelming evidence, was able to influence and not get the real truth out about what nicotine does for health. And we know in one way or the other, because systems are not perfect, right? There's a lot of great things in clinical research and medicine, but there's things that we have to recognize, we have to be watchful of, right? These are scholarly papers written about these issues that exist, like pre-selection bias, only publishing positive results and not publishing the negative results. I've seen that. Transparency issues. We know that the pharmaceutical industry influences news coverage because, they pay for advertising. So there's a lot of scholarly articles about this conflict of interest. And there is a movement to try to improve transparency. So these people in this waiting room who know this and have some concerns, when you read articles like this, where people are dismissed because, they just following conspiracy narratives and whatnot, again, it doesn't include these people. It doesn't represent them. That's unfortunate. In Ayurveda, this is a picture of some blind sages, and they're all trying to examine the elephant, and they have different descriptions, and they're all right, but they're not completely right. You have to examine many parts of the whole and put it in perspective. So let's take an example. We know, these numbers are pretty straightforward, right? The efficacy of birth control is 99%. You kind of know what that means. And the cure rate for like early Lyme is 95% with doxycycline. You kind of know, yeah, there's a 95% cure rate. But that's not what often happens in medical dissemination of medical information, right? This is the concept of adhikaranam, overrepresentation of the evidence. So both views of this chart are important, right? You should know the big graph, but then you can blow it up and see the little difference. But you can't do one without the other. And that brings me to oftentimes when you see industry-based research, the absolute risk reduction is to show the positive outcomes, and then the relative risk reduction is to show the positive outcomes, and then the absolute for the side effects. So what do I mean by that? If you have a population and 2 out of 1,000 get a disease, and in the test group, only 1 out of 1,000 get the disease, well, that's a reduction of 0.5% absolute risk reduction. But you can also report the difference between the two numbers, the 2 and 1 is 50%, which is relative risk reduction. So when you look at, for example, the statin intervention in people who have very low risk, their ASCVD score is super low, and they have a 30 to 40% reduction in events, heart disease, but that really translates that you have to treat 217 people for 5 years to prevent one non-fatal MI. But at the same time, almost that same number of people you treat for 5 years, one gets diabetes. So that's important to let to physicians to talk about that and know, and for patients to know. And believe me, physicians, we trying our best, and we rely on, we can't read every single study in detail, and the way data is reported, I think it should be clearer. So, in secondary prevention, if you have a heart attack, you can see the difference between these numbers in events, mortality, the way they're reported. I would, like to know if I had to go on a statin and I had heart disease, I would want to know that, well, you have to treat 56 people for 5 years and you would prevent one death. And that's important. That's a valuable number. But me knowing that, or patient knowing that, some of us will be even more motivated to do other things, like with, a person quitting smoking, improving their diet, exercising. And some people won't, but we know that a good, honest campaign makes big differences. Like this part of Finland, their campaign helped them improve life expectancies by 7 years. And we know that, the smoking cessation campaign really did help in, the United States, for example. So another concept in Ayurveda is one should examine the argument and not attack the person. And of course, this is not exclusive to Vedic thought. I mean, Western culture and all over the world, people value that. But the reality is, I've noticed. I'll give you an example. But usually, if you have a scientist who has great credentials, like these doctors were published in peer-reviewed journals, and they had very specific critiques about statins. And those critiques were met by the media with attacks. Like there's a special place in hell for doctors who claim statins don't work. And these doctors won the lawsuit. And you don't hear about this stuff, right? There's a Niagara Falls of other information, but you don't hear about these things. And the media usually doesn't address the specific erudite points that the doctor is making, but they just dump a lot of other data, the same data that the doctors were questioning, and then it just gets watered out. And so I've learned that if there's somebody being repeatedly attacked for some scientific piece, it's really important to kind of dive a little deeper about what that's about. So the way treatment is given to a patient determines the outcome. And, that sounds kind of metaphysical, but it's an important aspect, like the mindset of both the Vaidya, the doctor, the patient, their perception, the quality of the herbs, like all these pillars, the assistant, it mattered. Was your patient in a state of fear? Was the physician in a balanced place in his or her head? And we know PREST amplifies efficacy. It's important. It's called placebo and effect, and you can have the opposite, a nocebo effect. So when you have a lot of individuals kind of questioning the narrative, you can unfortunately get the nocebo effect, a negative perceived effect to a statin because of this kind of environment. So it's a win-win situation for drug companies who want to help people and people who want to be helped, if we just amplify the way data is portrayed in a very clear, open way. So these people in this room are not represented because they don't get their vitamin D checked routine. It can be an expensive test. It's not a routine test. And if you have dark skin, it's especially a problem, but for all of these individuals, because nobody's really outside in the sunshine as a farmer for long hours, right? We're all at risk. We are all at risk for vitamin D, and it is at the very least associated with heart disease. And actually studies that show, well, this nutrient, we really don't know if it decreases coronary events. Well, it's because it hasn't been studied. A deficient group specifically repleted and then followed over time and checked for repletion. They don't have this stuff. They kind of have mixed populations, or they're studying only normal populations. There was at least this study, and it was presented at the American Heart Association scientific sessions, which showed a 50% reduction in people who have heart attacks who have vitamin D deficiency, and they were supplemented to repletion. We'll see if this gets published or if it gets, kind of watered down and there's no follow-up studies, because, vitamin D is not a patented drug, but, the relative risk reduction was comparable to statins and niacin. So I thought that was very interesting. Purighalla is a school of thought where you're looking at honest data, but you're seeing an illusion from it, right? So if I'm walking and it's dark and I perceive a snake, and but I flash a light and then I realize, oh, it's only a rope. That's important. And so when you look at nutrition labels, let's say your particular body type is you will do well in a low fat diet. Everybody's dietary needs are different. But and you look at this label and you think, oh yeah, this is only 10% fat. A lot of people do that mistake. The labeling has changed. They used to put the fat by calories here, so you wouldn't have to do math. You realize this packaged food is actually almost 30%, about 30% fat. But now you don't have that, and you have to actually literally, you have to take the grams of fat here, which is 8, and multiply it by the 9 to get this number. So that's a kind of a form of viparya. And in Vedic thinking, Ayurveda reality is very perception based. So here's some interesting quotes. But we'll give you an example. The yukti, the process at which a patient is going to arrive at a decision matters, right? So let's take somebody who's refusing a mammogram. If they say, well, like I looked at this data, only 1 out of 2,000 people screened, their lives will be saved. And then they say, but 200 to 500 people, they'll be misdiagnosed and have mistreatment and anxiety. The numbers are concrete, but for one person, this number may be outweighing the need for this. But another person, they might think, no, this number, saving life, is much more important than this. And so, that's where reality is very perception based. And the yukti of this individual, is going to be a different conversation. You could argue, well, thermograms haven't been tested and there's a danger to have false positives and false negatives. And, the radiation exposure is nowhere near as high as some daily exposures that we cumulatively get. But my point is not the mammogram issue. My point is the yukti and the perception of the patient, how they're perceiving the real the information matters. Pratyaksha is when you just directly observe something. So double-blind placebo-controlled trials are really important. Lots of data on low saturated fat diets, but in Ayurveda, there's no one-size-fits-all diet. And with my own eyes, I can see huge populations for so long are on very different diets. I mean, certainly these people are not on a low saturated fat diet, or these individuals. So I think there's more to the story. I myself am vegetarian. I am quite interested in this data here because they're very plant-based. So there's no one size fits all. And, sometimes in, science, we look too closely at something that can be valuable, but you can extract curcumin from turmeric and pepperine from pepper. And then lo and behold, somebody takes it in a high dose and they get liver problems. But in Ayurveda, there was an intuitive aspect as well, to look at the bigger picture, the more fractal part of the universe, to know, is turmeric and pepper and what dose and for who would this be wise to use? And that whole intuitive thing kind of makes many people in science uncomfortable. But it exists, and we should be cautious about it. We shouldn't just jump into magical thinking. But today's magic, when we dive deeper, might be tomorrow's science. We just figure it out. And here, I'm not making a plea to use psilocybin or LSD. I've never used it myself. But my whole point is that there are scholarly studies on that when we go past the linear thinking, that there is a value to a place in our understanding that goes, I'm going to use the word fractal, that goes deeper with deep problem solving. And this individual is a great example. Srinivas Ramanujan, he had no formal training in advanced mathematics, and yet he had all these answers for very complex mysteries in math. And later on, the proofs were given. He didn't have the proofs, but so this suggests a deep intuitive nature to even scientific thinking. So again, I am so grateful for the strengths of Western medicine. And I am also so grateful for the insights of these Ayurvedic schools of thought. And neither is perfect in human hands, but with open-minded, cautious skepticism, together they can offer greater potential to advance our health system. And I thank you so much for